Hi, welcome back to Surgically Speaking. Today we'll talk about trigger finger. Now, trigger finger is an important short answer question in your final year exams. To understand a trigger finger, we should recall the anatomy of the hand and the biomechanics of hand function. See, in the hand, God has created certain amazing structures, and one of it is called the fibrous flexor sheath. Now, they extend from the metacarpophalangeal joint region up to the terminal phalanx. Now, the base of this tunnel is formed by the bone and the roof is formed by the fibrous tissue. So, it is essentially a fibro-osseous tunnel. The inside of this tunnel is lined by synovial membrane. Okay? And through this tunnel passes two tendons, namely the flexor digitorum superficialis and the flexor digitorum profundus. Now, in certain places over this fibrous flexor sheath, we have some thickening, some differentiation of these tissues is happening, and we call them pulleys. The most proximal one is called the A1 pulley, which is situated at the entrance of the fibrous flexor sheath. That is at the metacarpophalangeal joint region. And subsequently, we have A2 pulley, A3 pulley, A4 pulley, and A5 pulley. In between, we have C1, C2, and C3 pulley. More anatomy, I want all of you to go and refresh from your textbooks. Now, the entire design is to ensure that the bowstringing of these flexor tendons do not happen when the fingers are being flexed. Now, that is the purpose of this fibrous flexor sheath and the pulley systems. Now, in certain conditions, what happens is that the entrance of this fibrous flexor sheath tunnel, namely the A1 pulley, becomes inflamed and it becomes thickened. When that becomes inflamed and thickened, the gliding of the tendon becomes difficult. Now, in due course of time, what happens is a fibrotic nodule also develops in the flexor tendon adjacent to the A1 pulley region. So, now the nodule in the tendon and the stenosed A1 pulley, both these things makes the gliding of the tendon very difficult. I hope you'll understand that. So, when a person tries to extend the hand, extend the fingers, this affected finger, it doesn't extend. And when the person tries to forcefully extend the finger, that nodule enters into that stenosed A1 pulley and one snap is visible. So, that is the biomechanics which I want you to understand. I hope I made it clear for you and I didn't confuse you. Imagine a bike cable. The outer sheath, the bike clutch cable. The outer sheath of the cable is the fibrous flexor sheath, and the wire that goes inside is the tendon that passes it through the tunnel. So, you can imagine that and try to understand what happens in a hand. Now, that is one thing, and this trigger finger usually is commonly seen in the thumb, in the middle finger, and in the ring finger. It is less commonly seen in the index and least commonly seen in the little finger. The reason being that when a person forcefully grips an object, the main tension is only through the ring finger and the middle finger. That is the one that gives maximum grip strength. The little finger is only to give some support, and the index finger usually is for precision. By artists and surgeons, the index finger is important. So, that is one of the reasons why this trigger finger is not seen so commonly in the little finger and the index finger. Now, when you get a patient with this condition, always rule out diabetes mellitus and rheumatoid arthritis, and also ask if his profession involves forceful flexing and extending the fingers. So, that much about the presentation, and we don't need to do any big investigations, any imaging to diagnose this condition, because diagnosis is usually clinical. Now, how do we treat? The first line of management will be conservative. We have to give rest to the affected part, and some doctors even inject steroids into that area. But however, most of the people will require a surgical release of this stenosed A1 pulley. So that is the management. The definitive management is release of A1 pulley. I hope I made it very clear and I didn't confuse you. I have made a short video for you which was shot a few months back. The video clarity may not be good because I shot it with my mobile camera. However, all the steps will be very clear and you will be able to identify and understand all the steps involved in the A1 pulley release procedure for a trigger finger. So let us get into the video without much delay. I'm sure you'll love it. I have marked the site of incision just distal to the distal palmar crease. Venkat, tell me if there's pain, okay? As soon as I make the incision, you can see the subcutaneous fat popping up. Bipolar. We should take care not to injure the tiny nerves that we come across. They are the digital nerves. Try to separate the fat and visualize the fibrous flexor sheath. Retractor. Forceps. So now you can clearly see the opening of the fibrous flexor sheath here. With the focus one. Can you see the fibrous flexor sheath here? And you can see the tunnel, the entry of the flexor tendon going through the fibrous flexor sheath. So it's very clearly seen here. Can you see this here? Yes, 15 blade. Now I will just demonstrate. Hold ma, put it. I will just demonstrate how the triggering takes place. Venkat, try to flex your. See? Wait. Yeah, Venkat, flex your finger. Extend. Straighten it. See that locking is taking place. Oh, enough, Venkat. Now this is the place. Okay, 11 blade. 15 blade. Where is it? I am incising the A1 pulley. You can see that I have incised the A1 pulley. This is the A1 pulley I am incising. You can see it getting released. That is a comfortable release of the A1 pulley. Now the next thing which I am going to do is I am going to lift the tendon above and see how robust the tendon is. And we try to release all the adhesions between the tendon. You might have observed that as I pull this, the finger is automatically getting flexed. Now these are the fibers. Can you give me that? Yes. Now the tendon is completely freed. This is the inflamed part of the tendon. Now see how the tendon has slipped into its place. Now when you try to do your movement, is it free?
There's no snapping seen now. Are you convinced? Yeah. So that finishes the procedure.
Stop.
30 echelon. After releasing the tourniquet, there will be tiny bleeders there, which I use a bipolar cautery to coagulate the bleeders. Yes, the wound is closed with 40 echelon. It is better to do this procedure with the loop magnification because it helps us to identify the digital nerves very clearly. Otherwise, the chances of injury to the digital nerves is very high, which will cause some numbness in the post-op period, but eventually that also improves. It looks at the end of the procedure. I usually stick a very small adhesive plaster and I instruct the patient to keep the limb elevated for a day, and he should be able to return to his work tomorrow. Thank you.